What about ligamentous lesions in the knee? Well, we're going to focus on a few very important ones. The medial collateral ligaments, the medial coronary ligaments, and the lateral collateral ligament. Well, there is a clear difference in story between an acute ligamentous lesion and a chronic ligamentous lesion. That's logical, yeah? In an acute stage, what do you hear? The patient had a trauma, yeah, of course. When you talk about MCL, it's going to be more a valgus trauma. When you talk about medial coronary, it is more going to be flexion lateral rotation trauma. Okay, but there is a trauma, painful. But let's imagine that the patient is a football player. He has a trauma, it's painful, but he still manages to continue the game with pain. And when he comes out of the shower, in the meantime, he has a swollen knee. He has a swollen knee with limitation of flexion and less limitation of extension. In other words, slowly but surely you see a capsular pattern. Slowly but surely you have the functional disturbance. Yeah? In a chronic lesion, that's a little bit different. There was a trauma sometime, but there was no active treatment. You know, the patient just got immobilization, yeah, or just rest, and then you know what is happening during the repair and the remodeling phase. You can get the formation of adhesive scar tissue, and then everything functions okay for activities of daily life. But every time when the patient performs some extra sports activity, well, then he still has a little bit of pain, a little bit of swelling, and then he has to rest again for a couple of days, and then it's better again. But activities of daily life, okay. More intensive activity, not okay. So that's the main difference in history. So the difference in history between acute and chronic is quite clear. Also in the clinical image, there is really a clear difference. In the acute stage of a ligamentous lesion, you see the obvious image of a traumatic arthritis. The capsular pattern is dominating. Yeah? You have a lot of limitation of flexion, less limitation of extension, swelling. It looks like a traumatic arthritis. But therefore the history is very important. The history is going to tell you what happened and most likely in which direction you could think. In the subacute stage, this traumatic arthritis, this image of the traumatic arthritis, this capsular pattern slowly but surely is disappearing, and the primary ligamentous test becomes more obvious. For instance, for MCL, the primary test is valgus. For medial coronary ligament, the primary test is lateral rotation. For lateral collateral ligament, the primary test is varus. Yeah? And in a chronic stage, then this capsular pattern completely disappeared. You just have a positive primary test and perhaps a slight limitation on a certain test movement. And that's going to be flexion. When there is a chronic MCL lesion, sometimes you find a small limitation of flexion. Again, because of ligamentous adhesions. So, if you look in detail at the clinical image of an acute MCL, swelling, capsular pattern, and which end feel? Muscle spasm end feel. Yeah, you have limitation of movement, you would like to go further, but there is a very clear muscle spasm. Valgus, your primary test, of course, clearly positive. and the passive lateral rotation can also be painful. So you can't miss this image. This is quite clear. The chronic image of an MCL is totally different. It is a clear non-capsular pattern. Flexion is slightly painful end range and perhaps a small limitation of movement. This is not a certainty. That could happen. Passive extension, end range slightly painful. Perhaps passive lateral rotation, end range painful, but that's not always the case. And of course your valgus as primary test is going to be positive too. So that's a completely different image if you compare that with the previous image. When we palpate the MCL, it's a pretty long ligament. It's a broad, long and flat ligament. You have to compare 3 localizations by palpation. Joint line, femoral part, tibial part. Always standard, check 3 localizations. Mostly the lesion lies at the height of the joint line. And what are we going to do with it? Well, in an acute and subacute stage, we're going to do progressive friction massage. That's exactly the same story as in the acute inversion trauma of the ankle. I refer to another film. But with acute ligamentous lesions in the foot, acute ligamentous lesions in the knee, you don't start with 10 minutes of deep friction. That would be too much. Just maximum a few minutes the first day. You see the patient every day the first week, then you see him every second day the second week. And you build up gradually the friction until you reach your 15 minutes at the end of the first week. But in the knee there is something special. In the knee, when we talk about MCL, we're going to friction in 2 different directions or in 2 different positions, in as much extension as possible and as much flexion as possible. And we do that in order to get a most optimal mobilization of that structure. We continue with active mobilization, and of course from the moment it is possible you do proprioception. That's logical. Yeah? In a chronic stage, well, the same as in the foot, lateral ligaments, deep friction, manipulation, and you continue with some mobilization and proprioception. But there is a specific strategy for the very first day. Remember, I just showed you the clinical image of a chronic MCL. Which tests are positive? Well, what are you going to do when it comes to therapy? First, you do 10 minutes of deep friction from an extension position. Then you manipulate once in extension. You manipulate once in lateral rotation. Those were the tests which were just painful in the clinical image. Then you do 10 minutes of deep friction from a flexion position, and then you manipulate in flexion. So you manipulate the movement over here, which is painful and limited. This is a strategy for the very first day. Okay? As from the second day, it's just friction, mobilization, proprioception. Well, this is the palpation and the friction of MCL in as much extension as possible. It's easier to work with 2 hands. It's always easier. Yeah? Put a cushion under the knee because he cannot extend fully, because remember, in an acute phase, you have this capsular pattern. And then, well, you keep the finger on the lesion and you move to flexion and you give another portion of friction in flexion. Keep in mind that now the direction of the ligament is more or less like this, so your friction massage is going to be more or less like that. Palpation for the lateral collateral ligament, therefore we use what we call the 4 trick. You just palpate in the lateral joint line from that position, And the first cable you feel, a real clear cable, this is the lateral collateral ligament. It lies pretty far in posterior direction. Yeah? Deep friction is just business as usual. Yeah? And then the manipulation in medial rotation, manipulation in extension, those are the easiest manipulations. You just go to the end of the movement and you do one fast impulse. It's high velocity, low amplitude. Or the manipulation in lateral rotation and the manipulation in flexion. Remember, the patient could have a slight limitation of flexion, about 5 degrees of limitation. You already did deep friction and some manipulations in the other directions, and then you finish with this one. You just go through the limitation. Very easy and not painful, because first you did already some friction massage, and thanks to the friction massage you have an anesthetic effect, and thanks to this you can manipulate in a comfortable way. Yeah? And then the palpation of the medial coronary ligament, so you have to put the knee in lateral rotation so that the medial tibial plateau becomes more prominent. You just do the opposite for the lateral coronary one, you go to medial rotation so that the lateral plateau becomes more prominent, and you just have to palpate on the plateau. Make sure that during your friction your thumb is always in a low position, that your fingernail is horizontal, that you have pressure on the tibial plateau. The moment your thumb is not there anymore, but your thumb would be on the other side, then you friction the condyle, but you don't friction the coronary ligament anymore. I also would advise to use a layer of cotton wool over there, because the skin could be quite vulnerable. Once again, I would like to emphasize it. Keep your finger, really keep your nails horizontal, and make sure you have a deep fulcrum or a low fulcrum with your thumb. That's the secret for this technique. Yeah? Well, I will show you all those techniques live, so stay tuned and have fun.
The friction is given in two different positions, in as much extension and flexion as possible. The knee is supported by a cushion. For a right knee, we use the right middle or index finger. We find the joint line and we palpate in a posterior direction until, beyond the midline, the ligament is found, a large, flat structure. The deep friction is performed in the normal way. For the deep friction in flexion, we find the lesion in extension first, keep our finger on it, and then bend the knee. The deep friction, again, is the normal execution. Notice that the direction in which the ligament now lies has changed, and so has the direction of our friction. It is also much easier to work with both hands simultaneously. We have to check 3 localizations for local tenderness: joint line, femoral, and tibial extent. We can use the 4 trick to locate the ligament. We palpate the joint line in a posterior direction until we feel a hard cable. We bring the knee into extension, and the normal execution of the deep friction follows. The starting position is 3/4 of flexion. With our forearm we bring the foot in dorsiflexion, then we use the medial border of the foot as a lever to reach full lateral rotation. After a few preliminary lateral rotations, a thrust follows. One hand is placed just proximal to the foot, the other just proximal to the knee. Both thumbs face anteriorly. The knee hand performs a preliminary flexion-extension movement, which is followed by a high-velocity, small-amplitude thrust with both hands towards extension. A few preliminary flexion movements, followed by a thrust towards flexion, thus breaking down the adhesions. The patient's knee is supported by the therapist's shoulder. The heel is grasped with both hands. Full medial rotation is repeated a few times and a thrust follows. The starting position is 90 degrees flexion and lateral rotation. For the right knee, we place the right index finger onto the tibial plateau. The fingernail faces upwards. In this way, pressure can be applied in a downward direction. The thumb should be put far down in order to maintain this pressure. We avoid a position with the thumb more laterally, since this would be a friction of the condyle instead of the ligament. A layer of cotton wool would be useful too. For a lateral coronary ligament, the knee is positioned in medial rotation.